So thank you. So my
It was
topic is
lovely.
ocular trauma. What's new? Salvaging the unsalvageable, salvageable, and operating on no PLIs. And I think I'm doing it boldly for long now, and I'm happy to share that. So extreme trauma can include corneal edema, hyphema, cataract, vitreous hemorrhage, commotion, retinal detachment, associated with subretinal hemorrhage, which can lead to no PL, except aversion of optic nerve. In case if it's there, I think no point in operating. But other than that, I think the whole thing is to reconstruct an eye which is useful and preserve the eye anatomically and keep the chance of a functional improvement irrespective of an initial complete functional loss. Despite repeated surgeries, the risk of sympathetic ophthalmia has not risen above 0.1 to 0.3% within the last 4 decades. In 1984, despite common strategy, Michael Belkin, who is my good friend from Israel, advised not to enucleate an injured eye only because of the risk of sympathetic ophthalmia and as long as the patient can be kept under observation. And this is very important. Even now, I know some people are doing primary enucleation or evisceration. Recently, it happened at midnight. Somebody, one of my patient called, said somebody had a bike accident and the bike hit. And then I told them to preserve, but somehow both the ophthalmologist and the other, I think two of them, they said they could not and they enucleated. I don't know. I think I'm not able to accept that we cannot, what do you call, we should enucleate. So, yeah, I'm seeing the timer is there on. So so I think I don't want to enucleate at all, however bad it is. And in 1980s, the treatment strategy was quite clear. If there's a little hope for a functional reconstruction, enucleation are advised to prevent sympathetic ophthalmia. Unfortunately, that is going on even now. And any eye that had lost the ability to perceive light was considered to be non-repairable, which is wrong. And I won't say wrong, which is not the current trend. So what is new is this is some studies I'm going to give. So I believe evidence-based medicine. This is Bob Morris, the president of American Society of Ocular Trauma earlier, and Ferenc Spoon, now the president of International Society of Ocular Trauma, have published. It was only 20 years ago that Bob Morris et al. Reported on their attempts to reconstruct 11 eyes with severe ocular trauma that could not perceive light, and the author succeeded in restoring some function in 7 out of 11 eyes. And according to an analysis in the World Eye Injury Registry study, 28 eyes of no PL in which a reconstruction was attempted, 21 patients regained light perception. And you may say, why we have to spend so many hours? And I did that in Kashmir. And 2 ambulatory vision below 20 by 200, again published by Bob Morris, which is 1999. And even in 21, I think 2021 it holds good. And another study done on 6 eyes with initial no light perception vision who underwent successful reconstruction and were able to maintain vision. I achieved a final vision of counting finger, achieved hand motion and vision, and achieved light perception. And again, this is from a different group. And this is a 4.3 injured eyes with a no light perception. Vision was as follows: one achieved visual acuity of 20 by 300, and one achieved visual acuity of 20 by 100, and then one achieved visual acuity of 20 by 40. This is by Alfaro and Peter Liggett. Peter Liggett has visited Arsene Shankar in 1986. He was in that time the Yale University. And my philosophy, which is what I talk, eyes with no PL vision should always undergo primary repair, even when the anatomical size is estimated to be less than 1%. And I think many times you save the eye, and that itself is a great thing for the patient. And strategic thinking in ocular trauma. All of us talk about management, that I'm talking about business management, the MBAs. Strategized thinking is individualized approach. Think again and again, and what's the suitable line of management for the given patient. And that's why logarithms are given by Steve Charles is very good. But you have to have, like the last chapter says, you have to play this like a soccer game, because the opposite team is the traumatized eye, and we are the VR surgeons who are going to repair. Thus, the decision when to perform vitrectomy will therefore continue to be made by individual surgeon. An extreme trauma can be due to intraocular foreign body, infection, suprachoroidal hemorrhage. And the timing of vitrectomy, I'm not going in. Here we had a fracture injury who are planned, and you can see. Oh, okay, the video is not working. No. So this patient had only counting finger 1 meter. So this I think should work. This is a 34-year-old male patient with history of blunt trauma in left eye with wiper during an argument with his wife. His vision in right eye was 6.6 and left eye was doubtful PL. And the first surgery, globe exploration, AC wash, and second surgery, 25 gauge with oil, and third surgery, vitreous lavage with the silicone oil, which I'll show you. So this was the finally the vision had retina. You can see retina crumple. I still feel like going and making 2-3 endo chandelier and go and do a 3D surgery to open up this, but I don't know. I just saw this patient last week. Best corrected. It is an argument between a husband and wife, and she took the that whatever she was cleaning and hit the eye, and the eye got. And at least the eye looks good. That's all I can say. And surgical traumatic endophthalmitis, and again this is with the character process. We can see it is a 24-year with a stone injury. And what happened? None of the videos are working. Oh, I don't know. I'm sorry. I don't know what's happening. None of the videos are there. Maybe I think I should take some other video. In the meantime, how much time I have? So about 3 minutes. Can I ask the second speaker to talk, and I take back the video and show only the video? So anyway, with this talk, I want to say that don't inoculate or eviscerate primarily. Repair whatever, however bad it is, and then even if the sclera is gone, in case you have a preserved sclera, do it. So maybe I have 3 minutes, which I can show the video next. So you can call the next speaker. So this is Ferrum School, and then this is the preoperative where the wound repair was done, and then the total cataract with vitreous hemorrhage and CT scan done as rightly plotted by Sonal. This is all done in Kashmir. And this one patient came to Mumbai. So here we have a past vitrectomy intraocular deformity. Thanks to Dr. Manish Bape and Mahesh Shanmugam. They made a nice 4-prong forceps. So that's what I'm doing. After doing a lensectomy vitrectomy, making an incision at the 11:1, and then within the vitreous hemorrhage, when the pellet is engulfed, I remove it. So whatever may be the vision pre-op, I always operate because it is like a war-struck area, so it's like a civil war. So everybody was after all the politicians and the journalists. So this is how the pellet was removed, and there's a nice forceps created by Dr. Manish Bape. And if you see, the injury is next to the optic nerve, and then remove the exit wound and do an endolaser around that, like create it like a coloboma choroid, and then do it, and then do a fluid air exchange. So the retina was attached, and whatever may be the outcome, anatomy, the visual, I think anatomically you should do the best. Sometimes the pellet goes through the optic nerve, through the macula, and those points. And this is one of the patients where we did a cataract, IOL, for vitreous hemorrhage removal, submacular hemorrhage, and you see the optic disc and the silicone oil in situ. And this is a follow-up after 1 month. And then the traumatic ophthalmitis is a problem. So you can see this is a stone injury, but the patient came to me 20 days later, and you can see I planned for I played the Flaringa ring, and Dr. Kavita Rao is doing the corneal button. When she was doing it, the anesthetist said, I think the eye needs to be eviscerated. But I said, and all of you know, Dr. M.M. Sharma was the anesthetist, and you can see the eye is so inflamed because of the severe endophthalmitis. In spite of that, I know the patient may not get vision. Being a trauma, being a young boy, I decided meticulously to clear the infection. You can see the entire infection. And then, doctor, you can see the flaring ring. I wanted to do a keratoprosthesis, temporary keratoprosthesis, and do it, but now I am using the keratoplasty. And Dr. Kavita Rao said, you are wasting an eye. But I said, no, at least you can use a preserved cornea. And if things are working well, we can do a second patient. And the other is a suprachoroidal hemorrhage, where this is a cricket ball injury, and you can see the corneal switches there. I started with the AC maintainer. And since I don't know, when I make a trocar, only enter halfway, you can see the suprachoroidal hemorrhage being drained. And I put like that 4 ports all around. And then I drain the fluid, and then I try to make the other incision. You can see we don't know because of it was like a kissing corneal and the ultrasound. Subretinal fluid. Suprachoroidal hemorrhage. And then you can see that one more posteriorly. So the intraocular pressure is maintained through the intraocular pressure through the AC maintainer. And then you can see all the things are drained. And I make a 3-port through the limbus, and then proceed with the vitrectomy surgery. So however bad the injury is, you can see post-operatively counting fingers in that eye. 1 meter, and that was the thing. Thank you very much.